Okay, so for our speaker today, we are grateful to have Dr. Ahmed. Dr. Ahmed, he received his medical degree from the Tehran University of Medical Sciences and completed his pediatric residency at the University of Calgary, followed by his pediatric hematology oncology fellowship at U of A and U of T. Then he subsequently completed a clinical and research fellowship in hemoglobinopathies and iron overload at the Hospital for Sick Children in Toronto. Prior to moving to Vancouver and starting his current role as a pediatric hematologist at BC Children's Hospital in 2021, he was an assistant professor of pediatrics at the University of Ottawa and a pediatric hematologist at Children's Hospital of Eastern Ontario. Currently at BC Children's, he's the director of the Hemoglobinopathy and Iron Overload Clinic. And he will be sharing his presentation with us about hemoglobin, Bart's, and Hydrops Fetalis. So I'll let you take over there for screen sharing, Dr. Ahmed, and thank you very much.
Excellent. Thank you so much for the introduction. Do you see my slides?
Yes, we do. Thanks.
Okay, perfect. I have two windows, so I have to look on the other window. So if I'm not looking at the distance in the future. So, thank you so much for having me. It's exciting, and I'm honored to present. This is something that we all have read in the books. We rarely have seen in kind of in practice these people with this condition, but I think this is something that, as our standard of care increases, especially worldwide, we're going to see more and more of these individuals. And then we do have patients in our clinic, and probably there would be more and more in the future. So I thought it is an interesting thing to present, but also it has implications for treating the much more common thing, which is hemoglobin H disease, and how we offer transfusion to these individuals. So just before starting, I do have some disclosure to say. I've received consultancy. Interestingly, none of these are from services for hemoglobinopathies. They're all bleeding disorders. So there is no conflict of interest for this presentation. So just a little bit of an introduction. I think you all know this more than me. As you can recall, each gene, it has exons and introns. Exon is the one that will exit the nucleus and participate in the final protein production. Introns are the part that are necessary for RNA production, but they would stay in the nucleus and do not participate in the final protein. And then you have a promoter region, and also you have a Lucas control region far away from the gene itself, which participates in initiation of the translation. As you know, in a normal adult hematopoiesis, you have alpha gene or alpha-like gene and then beta-like genes participate together through the process of development. There are different aspects of the genes that are becoming involved. But here, depicted in an adult, you can see that there is a harmony exactly between the amount of beta or beta-like globins that you make versus alpha-like or alpha here globin that you make. And they're exactly the same amount. So they're absolutely incoherent, and then they produce the hemoglobin tetramers without any extra globin chains that are left unattached to its counterpart in alpha versus beta. But when you start to get mutations, you can have a mutation in the exon regions, and if that leads to a production of a protein because this is in a part of the gene that will participate in the protein at the end, then you're going to have a abnormal protein. Our discussion is about alpha thalassemia. This is something like a hemoglobin constant spring mutation, but the great example of it, like a sickle cell mutation as well. These are generally called hemoglobin variants. If you have a mutation in the intron region, if it leads to a problem with the production of the mRNA, or if you are just missing a gene completely, then obviously you're not making enough of that globin, and then you're going to have a disruption of production of enough or absolutely none of the hemoglobin. Here, these are basically called thalassemia syndromes. So the thalassemia syndromes arise from an imbalance production of alpha globin and beta globin. And this imbalance is quite important. It is not just you make something less, it is more important that you are making an imbalanced production of each. It is, as we know, one of the most common genetic disorders worldwide. At least more than 50,000 patients with severe thalassemia are born each year, and more than 1 million pregnancies are affected of a clinically significant thalassemia. The problem here is that because these are from areas that historically are from low or medium income countries, and this just significant impact of this condition on the population, on the healthcare system is significant. It can affect the quality of life, depends on the severity quite a lot, and has significant implication for patients as well. So just very brief, I think, and this would be something that highlights what we're going to talk about the hemoglobin Barts going forward, is that when you look at the beta thalassemia, can you see my cursor moving? Okay, perfect. So here you can see that here, this is the alpha gene that produces, as it should, the alpha globin, but on the other side, the mutated beta gene produce a protein that gets degraded right away, or is not a kind of a functional. And what will happen is that there is a reduced amount of the beta-like globin that you make, or none. And here, this is a beta 0 mutation, and what is left is only a very minute amount of the delta, but a lot of gamma chains, and then they produce hemoglobin F, and the remnant of the alphas that have not been coupled with the beta-like, they will aggregate, destroy the red cells very early on in the erythroblast, and leads to ineffective erythropoiesis after the cell death. So here is that because this is happening so early in the erythrocyte production, they don't even get a chance to come out of the erythron, and then what will happen is that they just get destroyed in the marrow. So that would lead into hemolysis in the bone marrow, basically. So when you look at it, this reduction of the beta globin, what it means is that it's going to be a lot of free alpha globin forming an aggregate, creating a hemoglobin in the bone marrow. So here you do not see any reticulocytosis, depends on the severity. If it is like a beta 0 mutation, you may see absolutely no reticulocytes, or very, very minute amount. With that, it comes splenomegaly due to extramedullary hematopoiesis, trying to help the bone marrow to create red cells. Again, that is non-functional, and this vicious circle goes on. And then if you look at the hemolysis, you'll see that the hemolytic profile is not as severe as what you would have expected with the same amount of anemia, let's say in someone with spherocytosis. So there is a moderate or mild amount of peripheral hemolysis with elevated bilirubin or LDH and things like that. So this erythropoiesis eventually leads into extramedullary hematopoiesis and this thalassemia phases that we all know, but also because of the problem with the iron regulation and hepcidin pathway, the body always evolutionary has thought that anemia means iron deficiency, and then starts to absorb iron, although it does not need iron, and that would lead to slow iron overload, even in the absence of any transfusion. So the treatment of the thalassemia patients, here we are talking about the beta thalassemia, is basically the cornerstone of it is transfusion. Transfusion would increase the hemoglobin and resolve the anemia, allowing a good transport of oxygen in the body. But also more importantly, also suppress the ineffective erythropoiesis, which is quite a consuming process, leads to a lot of energy expenditure in the body, additions the burden on the heart, and leads to kind of a major problem that is associated with thalassemia. It also reduces the size of the spleen as it reduces the ineffective erythropoiesis. As the spleen shrinks, there would be more blood in the periphery, so it kind of circles back to the effectiveness of the transfusion later on. So we have learned over decades of how to practice transfusion in people with beta thalassemia. We have gone through the phase of just giving transfusion if the hemoglobin is low, to starting a regular transfusion, keeping them almost normal, to now a phase that we say kind of a conventional transfusion, where we think that if you keep the blood hemoglobin above 90, it should be good enough to suppress ineffective erythropoiesis, offer good enough amount of oxygenation to the tissue, keep the spleen in the normal size. And if we do that for people with beta thalassemia, you'll see that they basically grow well and function well, and they meet all the milestones, and hopefully they will live as long as everybody else. But after a lot of transfusions would come the significant iron overload, which body doesn't have any means to get rid of it, so you have to couple it with iron chelation. So if you're in an area that you can offer good transfusion and good iron chelation, basically the outcome of the thalassemia is very good. But if there's a limitation of offering any of these, which would be most of the other part of the world, then that's a significant issue for the people. So our talk is basically today about alpha thalassemia. So just kind of a very simple review of it. As you know, the alpha globins are duplicated genes on the chromosome 16, and then a normal adult human has 4 alpha genes. And then if you are missing one, or one is mutated, then you will be having a carrier states here. And then if you're a carrier with missing gene, basically there's no hematologic abnormalities. If there's a mutation, depends on the type of the mutation, there may be some degree of microcytosis and rarely anemia. But if you're a minor, meaning that your 2 genes that are deleted, these individuals will have microcytosis and possibly some mild anemia or not. The only implication of this is that it is basically now, because you're missing half of the genes, this is quite like beta thalassemia minor, that you're missing 1 gene. So again, that doesn't have any clinical implications beyond prenatal counseling and for family planning. And the important one is also the one that is actually 2 genes are missing from one area, the ones in cis. And then hemoglobin H disease is when you have basically either 3 genes that are missing or 2 genes that are mutated. The mutation, in addition that you do not produce enough of the normal alpha globin, it also adds burden by creating some other form of problem in production of the red cells. For example, now it becomes something like a variable hemoglobin, may cause ineffective erythropoiesis, may create an unstable hemoglobin. So having a mutation in the alpha genes are generally worse than having a deletion of the alpha genes. So if you have 2 genes that are deleted and 1 gene that is mutated, this is rather on the, in general, not always, rather on the end of the spectrum of the alpha hemoglobin H disease with more severity. And the talk of today is basically the alpha thalassemia major, or hemoglobin Bart Hydrops Fetalis, where you have no alpha gene. So I depicted you here that there are the genes when the alpha, both alpha 1 or HBA1 or HBA2, the 2 genes are missing from 1 gene, and you can see that there are some that goes beyond the HBA1 and HBA2 and involve the HBZ. And this is important because you at least need 1 Z, like HBZ intact, so that you can just pass the very early embryonic phase. And without that, having also HBZ deleted is absolutely incompatible with life. The most common deletion is the C deletion, that it is highlighted red. Very fascinating also is that all of these deletions, they are thought that they cause from a recombination. So what happens is that from one chromosome 16, the gene is dislocated to the other chromosome 16. So the idea is that for each gene that is deleted here, there is a gene that is added in someone else's. So we do get people with triplications and quadruplications of the alpha genes, though because they are not they probably haven't been important in terms of the evolution and protection against malaria. They haven't been selected to be more, but certainly there are individuals. So as I said, when you see the imbalance, but you do your beta genes, and then you see that, oh, there's no problem, but the features of a thalassemia is there, you always have to see, okay, there's not enough missing, but can be an extra one present somewhere else, and then you have to look for it. So this is probably one of the most common diagrams that we all see in medicine. At least I'm kind of a prejudice against it being a hematologist. So, but what you can see is that there are different phases of developmental erythropoiesis. It starts from the embryonal phase, and as you can see, the alpha globin very early on would be the only alpha-like globin that is being produced. As you can see, even very early on in the embryonic phase, there is alpha globin that is being produced, but also there is also zeta globin that is being produced. And as we go through the embryonal phase, zeta chain will go down, alpha will go up, and then you reach the phase of basically a transition from fetal to adult. Here, the beta still is not being produced that much. Now, epsilon from the beta side will be picking up by the gamma. And then after the child is born, slowly the gamma will change to the beta, and then where you're going to get to the adult life. So here, as you can see, that you can get many different types of hemoglobin in the embryonal because of all these different alpha genes that are being produced, and then switching from epsilon to gamma. But when you are missing the alpha, basically the only thing from alpha-like would be the zeta. And then when you get to the fetal life, there is no alpha-like hemoglobin to being produced. So here, the gamma that are left uncoupled with an alpha-like globin, they will form hemoglobin Barts. The problem with hemoglobin Barts is that it has a really high oxygen affinity. It attaches to oxygen really highly, and then doesn't release it to the tissue. In a sense, it is non-functional. You may have a very little amount of hemoglobin Portland 1, which is some remnant of the zeta globins that are being produced with the gamma. They will create a hemoglobin Portland 1. If you are lucky and then survive this phase without having an intact alpha, then when you get the postnatal phase, because of the switching from the gamma to the beta, now here you only have beta, creates beta 4, and that's hemoglobin H. And that is what the hemoglobin H is named after, that you're here now creating beta 4 globins, and that's why we named the hemoglobin H disease as such. So before that, I wanted to highlight also the differences again between primitive or embryonal erythropoiesis versus definitive erythropoiesis. So as you can see, HbA, HbA1, HbA2, and HbZ are all intact. They're close to the enhancer region, which is that locus control region far away. They create a transcription hub, and that will produce the zeta and alpha chains. From the other side, I didn't I'm kind of looking at it from the vision of the alpha globin. You create enough amount of beta, like here. This is epsilon because this is embryonal phase, and then you create your GAWR1 and GAWR2 hemoglobins. Everything is good, in perfect harmony, no problem. But when you come to the definitive erythropoiesis, what will happen is that the NORD complex is probably would remove the HbZ from contact with enhancers. And now you only have HbA1 and HbA2 that being in contact with enhancer and start to produce the alpha chain. So now there's no zeta chain here. As now we are beyond the embryonic, this is early phase of the definitive erythropoiesis. The gamma chain will come and form hemoglobin F. But if you have a Bart's Hydrops Fetalis and basically you are missing the alpha chain, what you can see is that there is no HBA and HB2 being produced, no alpha chain is being produced. And the HBZ, although it is removed, there would be what I can call it the leak of a kind of a trickle amount of zeta globin will come out. It may create just a minute amount of hemoglobin Portland, but the remnant of the beta globin that are being properly produced, they either form gamma 4, which is basically the hemoglobin Bart's, or later on beta 4, which would be hemoglobin H. I would like to highlight this versus the beta thalassemia, if you recall. Unlike beta thalassemia, where the alpha chains cannot form a hemoglobin, here you can see that the remnant of, or the uncoupled beta chains and gamma chains, they are able to create a hemoglobin that is relatively stable, because that aggregates that is toxic to the membrane is not produced right away. Here, you will not have as much of ineffective erythropoiesis compared to the beta thalassemia. So in a sense, this is a hemolytic process, because then later on they will create a rigidity of the red cells, and then they will be picked up by the spleen. So highlighting that difference between beta thalassemia, I think that what drives all of our discussions going forward. So you all know better than me that alpha thalassemias are also evolved like beta thalassemia, G6PD deficiency as a mean to protect against malaria endemic areas, and they are also common in what we call thalassemia belt. But I wanted to highlight that to have a clinically significant alpha thalassemia, you do need at least 3 genes that are deleted. And because of that, you at least need 2 genes deleted from 1 gene in cis. So from the clinical perspective, here alpha-0 thalassemia is the one that is meaningful, and we would like to recognize and diagnose as a kind of a population screening means. So as you can see, although the alpha thalassemia is quite dispersed throughout the world in the thalassemia population, the important ones, alpha-0 thalassemias, are kind of historically, they are coming from Southeast Asia, or a little amount from the Mediterranean area. In the Southeast Asia, it says it's quite significant. This is a study from Thailand that you can see in a certain area, the rate of having alpha-0 thalassemia is 10% of the population. So just to have a homozygous alpha-0 thalassemia in that community, you can just guess that out of 100 pregnancies, 1 would be affected. I would like to recall you that Down syndrome is 1 in 500 pregnancies. So you can understand how the significance of this condition would be for areas that is a high kind of a rate of alpha-0 thalassemia. So here, if you want to look in the global kind of a distribution of homozygous alpha-0 thalassemia or hemoglobin Bart's Hydrops Fetalis, as we discussed the area that, of course, the alpha-0 thalassemia is common, but ironically, we are in the place that you can see that there's highlighted more, and it is just the aspect of the human migration and the globalization of the populations. So it is now really a condition that should be considered across the world. So it is, as we discussed, it is actually the most common cause of Hydrops Fetalis in Southeast Asia. And we should also be preparing our community, especially in BC, that we are, our community, a good proportion of us are from Southeast Asian or any areas that is the alpha-0 thalassemia is endemic. So I thought that it would be nice to have a kind of a historic overview of this condition. So the hemoglobin Bart's is actually very interesting. It was the first hemoglobin that was named after they ran up all the nomenclature, like after like A, B, C, D, the alphabets. When they were run out, the hemoglobin Bart's was the only one, the first one that was named after something beyond just a kind of an alphabet. And they named it Bart's because it was found in the St. Bartholomew Hospital. So that initiated our practice that when we find a new mutation in one of our globin genes, we name it either from the area that the person comes from or area that is found, like a hemoglobin constant spring, for example. And then as they found it in England, right after, they found a patient that they identified that was born with hydrops, and they could identify these hemoglobin Barts in that individual from Indonesia. So so that was the first case of association with hemoglobin Barts with Hydrops fetalis. It took us almost more than a decade to now understand that a lot of people from Southeast Asia now present with hydrops. There was an association with having a significant amount of hemoglobin Barts. So it becomes kind of understandable that sounds like there's a syndrome here that they recognize. And what they saw is that all of these fetuses, they are basically miscarried or born very early on as a stillborn or die right after the birth with Hydrops fetalis. But also interestingly, they saw that there's a lot of other anomalies in these kind of patients that are observed that you do not see with other kind of anemias, for example, the hemolytic disease of the newborn that they come with hydrops. So there's a quite high degree of genitourinary abnormalities only in male, and also a lot of digit and bone abnormalities in male and female. So that was a curious aspect of these patients, and to date, we have not figured out why exactly that's the case. 10 years later, we started to really understand the physiology of it. And what we now understood is that the hemoglobin Portland, which if you can recall, was the zeta-2, either gamma-2 or zeta-2, beta-2, they saw that there is some degree of that being continued to be produced. Here you can see in this individual with hemoglobin Bart's Hydrops fetalis. And curiously, they saw that the more hemoglobin Portland you have, you probably would be able to survive more throughout the process of pregnancy. And it was very curious because these patients only have very little amount of hemoglobin Portland, but we essentially know that hemoglobin Bart's has no function. And it was fascinating to see that how these people who have 80% of their hemoglobin is non-functional can survive throughout the pregnancy to the late stage of the pregnancy. Then now 30 years later from when we defined the hemoglobin Bart's, the Journal of Pediatrics reported the first 2 long-term survivals. And long-term, I mean just past the neonatal phase of people with hemoglobin Bart's Hydrops fetalis. Curiously, both of these cases had high, around 20% of hemoglobin Portland, meaning that having a higher hemoglobin Portland, and we don't know why some do have higher hemoglobin Portland and why they don't, it is associated with increased chance of survival to term and possibly living beyond. Obviously, these patients that are born, they're right away, they're being transfused with red blood cells, as we know that they don't make any basic effective cells going forward. So they are transfusion dependent, essentially. Another interesting aspect was that quite right after that, less than 10 years, they started to say, okay, so if some patients can survive, why don't we start to transfuse in utero based on what we learned from hemolytic disease of the newborn? And then the first report of intrauterine transfusion that was associated with survival beyond the neonatal phase was reported. And intrauterine transfusion is basically just a process that you give the blood to the fetus through the placenta, and that allows them to have enough red cells that are functional to carry oxygen and allows them to resolve the hydrops and then survive to term. And right after that, they said, okay, so if we can keep these people alive, why don't we cure them with transplant? And see that the application of transplant was very early adaptation right after we start to do IUT. So these are all now providing us some insight of and some hopeful kind of a perspective for going forward. So these are, I wanted to highlight all the case reports by the hemoglobin Bart's Hydrops Fetalis. As you can see that these are the cases that are born without IUT. Right after IUT application was shown, you started to see a significant rise in the number of reported cases of hemoglobin Bart's Hydrops Fetalis. And then after that, there's a kind of a reduction of the cases. And it is not that the people were not just interested to report, because we look back at and we created a registry, we talk about it. It is just that truly that the number of cases reduce. And the reason for that was that although we found that IUT is very helpful in keeping these people alive, they noticed that now as they're aging, there's a significant concern with the neurodevelopmental process. And some of the patients, they have significant deficit in neurocognition. So that now it is really concerned that, is it a good thing to offer these people intrauterine transfusion if now it's going to be, one, a thalassemia, which is a chronic disease, two, on the top of it, now you have neurocognitive problems as well. So because of that, we started to create an international register in 2017 to really understand what's going on rather than just looking at the case reports. So the international registry, the first report was published in 2017. And from 13 countries, a lot of them were not in Southeast Asia. 69 cases were registered. There was more male to female kind of a long-term survivals, and we couldn't figure it out beyond just thinking that maybe because of the one-child policy, maybe they just kept more the males alive more than the females, which is kind of the disparity of the care for the female, because we saw the equal amount of patients getting to term or late stage of the pregnancy by both male and female, and then no really difference between male and female getting to the long-term survivors. As you can see, great majority of them were just born and less than 10 years, but there were like 18 of them, there were more than 10. This is almost 10 years ago data, because they're going through the publication and everything. So now I can say that these are all adults. So there are 20 patients with hemoglobin Bart's Hydrops Fetalis as adult right now across the world. Here you can see that majority of them were preterm, and very little amount of them had intrauterine transfusion, while like 40% they were just diagnosed postnatally and started on transfusion postnatally. You may say, okay, so is the chance that not transfusing 40% versus 60% in terms of the survival? But I just want to highlight that there are vast and huge amount of people with Bart's hydrops that do not get transfusion, and only 28 of them survive, basically. So this is again highlights the significance of intrauterine transfusion for these individuals. And as you can see that there's 20% of them have gone through transplant, and then there were 2 mortalities. Now there are more updated, and almost all of these were because of the transplant process. So when they looked at the data, they saw that almost all aspects of the perinatal care or neonatal care was significantly affected if you were not giving intrauterine transfusion, highlighting the importance of intrauterine transfusion for perinatal outcomes. I don't go through all of them, but almost every aspect was important and affected by not intrauterine transfusion. What was curious was that not a lot also, whether you to offer intrauterine transfusion or not, we saw that the spectrum of growth delays, growth deficit, and also neurocognitive deficit. There was no difference between whether you were offering intrauterine transfusion or not. However, I would like to highlight that this is a retrospective international registry, and there is a diverse practice of giving one transfusion, giving at the third trimester versus first trimester. So there was not a unified approach to this. So there is this cloud that really can we improve the outcome if we do offer intrauterine transfusions for these individuals. But nevertheless, you can see that the growth and neurodevelopment was affected in good number of patients. So then we thought, okay, so why don't we look at the individual approach in one center that they have been exposed to many of these individuals. So one report from Princess Margaret Hospital in Hong Kong over 15 years reported 6 babies that were born alive with Hydrops Fetalis, like a Bart Hydrops Fetalis, without any previous IUT, and all of them passed away, except one. Meaning that this, although some will live beyond, are born, they still die very, very early on. But just to recall you, this is an area that they probably every year they have hundreds of pregnancy affected by hemoglobin Bart Hydrops Fetalis. So when you look at it, this is significant poor outcome if you do not offer IUTs. Queen Mary Hospital offered over 20 years 3 patients who received intrauterine transfusion and all survived. And then they offered them bone marrow transplant later on. Again, highlighting importance of IUTs. And then San Francisco cohort, they over 15 years, they had 2 survivors, 3 patients who survived and then 2 received transplant. All of these highlights the benefit of IUT, but what it doesn't answer that what would be the long-term effect. By here, this is 2017, really there has not been any data beyond just the neonatal phase, except the discussion about the poor neurocognitive outcome of these individuals. So what we thought is that, okay, so why don't we try to answer this question of this tropical disease really in Ontario? So it's kind of a funny when you think about it, but the reality is that Ontario was the best place to do this. And the reason for that is that you all know Ontario is the most populous province in Canada, and it has a large minority of people who are from ethnic backgrounds from Southeast Asia, where alpha-0 thalassemia is common. So we had probably enough exposure to address this question. The second thing that was very important and helpful was that Ontario only have one single laboratory that does all the genetic tests, so that they had every individual that was diagnosed with kind of a homozygous alpha-0 thalassemia, they have this registry available to them, and they have the database of those. And then added to that, there was only one kind of a high-risk maternity clinic in the province that would offer this to people with hemoglobin Bart Hydrops Fetalis. At least at that time, I think maybe this has been expanded since then. So we did have all the data relevant to the perinatal outcome available for us. And lastly is that we have a very cohesive, 4 large hemoglobinopathic clinics in the Ontario that would have cared for these individuals. Interestingly, only 2 of them had the patients with alpha thalassemia, the hemoglobin Bart Hydrops Fetalis. So it was very easy for us to collect the data for the long-term survivors. And also, one thing that was kind of quite nice is that we offered consultation for in Toronto for the other 2 patients that were born and then we cared for not in Toronto. So all the patients have really treated equally and with the same protocol basically. So what we found is that really the every year there were 4 or 5 affected pregnancies that was identified with this condition. And here also it highlighted that if you have a field deletion, that in addition to the alpha-1 and alpha-2 that are missing, zeta globin is also missing. If you have missing one, it is compatible with life. But if you miss 2 of them, so there is no homozygous field deletion that can lead to any long-term survivor. But if you have one, that's good enough. And that is from the physiologically, it is an interesting observation. Here, as you can see, I also wanted to highlight that only 2/3 of them around were diagnosed as part of the screening. And then 1/3, they were diagnosed after pregnancy, either through the Hydrops presentation or after the birth, or after the kind of a termination of the pregnancy, or with the kind of a with basically stillbirth. So that means that we have to do better job in identifying people and pregnancies who can be at risk for having a child with hemoglobin Bart Fetalis. So here you can see that we identified 99 pregnancies. Don't go through it too much, but if you offer intrauterine transfusion, there is a chance of survival. If you don't, there was none, so nobody survived. But also it was important that if you were offered intrauterine transfusion, if you did it at the 3rd trimester, half of them did not survive. But if you were offering before 3rd trimester, all of them survived. One patient died later on because of the infection, but not because of the Hydrops Fetalis. So this is, I'm not going to go through the detail of it, but basically just replicates what we saw in the international registry, that if you do not offer IUT, there's a higher chance of preterm labor. There's a significant increase in chance of IUGR, and really that first like a 3rd trimester before and after probably is important. The later you do it, the chance of perinatal survival is less. We did also see that all the male newborns, they had genitourinary abnormalities. Half of the individuals had bone deformities, and a couple of them had severe, like the whole hand was missing, or the whole leg was missing, and we did see that there's a higher risk of portal vein thrombosis as well. What we saw, and now remind you that these are the first report of the long-term survivors and what we see in people who just beyond neonatal phase. So one thing that was not surprising for us, but it was surprised the degree of it, was that because all of these neonates that are born already have received 1, 2, 3 transfusions in utero, and then right after birth they start transfusion. And this is quite in contrast with beta thalassemia, that you start transfusion when they're 1-year-old, 2-year-old. They start to load iron very early on. By 1 year, they're already significantly iron overloaded. So that is quite significant. The reason for it is that we don't know the chelations, how much they are safe when you're offering it to basically a toddler or like a less than 1-year-old infant. We do know that the earlier start of chelation may be associated with a lot of long-term outcome. Also, it may be associated with developmental problems because of the, if you don't offer enough iron to your brain, for example, due to chelation. So this is quite challenging. And this is something that we haven't figured how to chelate these very young infants that they have received many transfusions already by age 1. And then when we look at the long-term outcome, it was reasonable at the time. It was, except one patient that had some below average. The other ones, I don't know, like the attention and memory is below average. This is me, basically. I have like a 0 attention and memory. So in general, I can say that they were acceptable neurocognitive outcome, at least in our population. There were 5 of them that we studied because this is really to properly assess neurocognitive outcome. You have to do it at kind of a school age. Curiously, since then, we have seen some of them who did well at the beginning. They started to drift kind of as they get older. Going forward, there is a report from, again, San Francisco that they looked into, see that the earlier or more frequent intrauterine transfusion, if you offer, would it be associated with better neurocognitive outcome? And they reported a really good correlation. But again, mind you, this is only very early childhood assessment. So it's really interesting to see as they grow how the neurocognitive outcome would proceed. Of your interest, the patient 3 is one of the patients that survived but got the intrauterine transfusion after the in the third trimester. So this is kind of anecdotal and one that you may have a little bit poorer neurocognitive outcome if you offer it DIUT later in pregnancy. We look at their growth. The top part is beta thalassemia, the bottom part is alpha thalassemia. As you can see, the people with alpha thalassemia were and alpha thalassemia, I mean alpha thalassemia major, or hemoglobin Bart Hydrops Fetalis. They had much poorer growth compared to the beta thalassemia. Mind you, all of these patients have been treated exactly the same as each other. And then when we look at the endocrine complications, almost all of the people with alpha thalassemia major had endocrine complications, some of them few different type of endocrine complication as compared to the beta thalassemia major patients, that a minority of them had endocrine complications. So here says that the long-term outcome from endocrine perspective is also different. The question is, why is it the perinatal phase with poor kind of oxygen delivery to the tissues that has affected the endocrine development years later? Is it early iron chelation? So it has become kind of an interest of us why the cause of it is. We also look at the brain to see why some of them, they may have poor neurocognitive outcomes, especially after we saw that some of them did well early on and then later on developed some challenges. And what we saw is that out of 5, 3 of them had this what we call silent infarcts. And I don't know, you probably have heard it when we talk about the sickle cell disease, about this silent infarct. And this is what we see also in these people with alpha thalassemia. Here, now it became a picture for us and a curious kind of observation, because in beta thalassemia patients that are well transfused and chelated, we do not see these silent infarcts. We do see them in people who are non-transfusion dependent thalassemia, especially if they're coming from an area that they were not being cared for properly. Adding to that the endocrine problem, adding to that the growth problem, now we are getting a picture of these individuals also being properly treated like a beta thalassemia patient, but they have features associated with what we see in non-transfusion dependent patients. So as we were looking into it, we saw something really curious and fascinating. And I've learned, I've burned before, using reticulocyte count as a percent. Like I've always thought that you have to report the count. But I had a point here, really. And I wanted to show that here you can see over years, these patients who have been treated properly, like beta thalassemia patient, started with some degree of reticulocytosis, going all the way to almost 20% as they get older. And again, remind you, this is not something that we see in the beta thalassemia. As I kind of revert, the transfusion would suppress the marrow. There would be no ineffective erythropoiesis. And also, ineffective erythropoiesis would lead to very little amount of reticulocytosis. So this was very kind of unusual for us to observe. Then we thought that, okay, so let's look at the smear. And what we look at, this is what we saw in the smear. Here you can see that there's 2 distinct cells. One are the donor red blood cells that are transfused, and the other ones, these golf ball cells, which is I think is a fascinating picture. These are the HBH cells that you can see these HBH kind of inclusions. And in hemoglobin H, you see the variable degree of the expression of these, and then some are fainted, some none, and then some is a little bit more. But here you can clearly see two population. Remind you is that these cells, because they are endogenously made, the only thing that they make is hemoglobin H in the cell. So this is what we call it hemoglobin H cells, because that's the only thing that they have. And then also, in pursuit of what the cause it, we saw that there's a significant splenomegaly in these individuals. Then we look at their electrophoresis, and very surprising of just how significant it was, but we knew that we're going to see this. You can see there's more hemoglobin H than the donor hemoglobin A. And this suddenly light above that, okay, so this is quite significant. The reason for that is that, like hemoglobin Bart, hemoglobin H also does not have any function. So what happens is that they are attached to oxygen so highly that it doesn't deliver it to the tissue. So here is a normal red blood cells. This is an individual with 5% hemoglobin H, and this is a hemoglobin Bart's Hydrops Fetalis individual. And you sense it's such left shifted that will have basically no function. So when you look at this individual, 60% hemoglobin H, 60% of their hemoglobin is non-functional, meaning that if you measure their hemoglobin and then you see it is 100, only 40% of it is a functional hemoglobin. So we came up with this concept of the functional versus non-functional hemoglobin. So we thought that for a person with alpha thalassemia to be treated properly, like what we do for beta thalassemia, you really have to look at the functional part of the hemoglobin rather than total hemoglobin. So the idea was that if you just look at the total hemoglobin, this non-functional part would increase the tissue hypoxia over time. The kidney will sense that there's not enough oxygen, increase the erythropoiesis, and then there would be an increase in reticulocyte in response to that. And just to remind you, because in alpha thalassemia, the beta 4s are able to form a hemoglobin, there's not a lot of ineffective erythropoiesis. So over time, slowly, the proportion of non-functional hemoglobin increased. The calculation of it is easy. You just reduce the amount of non-functional, the hemoglobin H from the total hemoglobin, that would be your functional part. So we said, what if we just look at the functional part and then transfuse them as if we are just looking at the functional? And then you can see the gray area is before you using the non-functional part, treating basically as beta thalassemia patient, and then after is that we now aggressively transfuse them, just looking at the functional part. And as you can see, all the markers, hemolysis and also ineffective erythropoiesis decrease over time. So we now started to employ an aggressive transfusion strategy for these people. There were times that we needed to I had to fight really with our nurses and transfusion team, that they said, why are you transfusing someone whose hemoglobin is normal? And then, it was quite a lot of kind of a challenge to finally go through the process and say that this is like a really unique circumstance. So just to show it again for you, here you start with someone who has just a little bit amount of hemoglobin H cells, mostly the donor. Over time, this increase in EPO, increased reticulocytosis would increase in the endogenous, poorly functioning or non-functioning red blood cells. And because of this, now there's more hypoxia because there's less amount of red blood cells that are functional, and this just sort of vicious circle. If you start a chronic hypertransfusion, and then here we also did some exchange transfusion to allow us to reach there, you can see that you will increase the proportion of the red cells that are functional versus the one that are non-functional, really allowing them to survive with offering them good amount of functional red cells. We were very curious, saw that we did some studies to see what is the best targets, and then hemoglobin H of 15% and a functional hemoglobin of 105 was really what we needed to go for in our transfusion. Curiously, this is like what you see in the deletional hemoglobin H disease people, that they have around 15% of hemoglobin H, and also their hemoglobin is 105, let's say. So really you needed to correct it to make them a hemoglobin H disease deletional type. But to really reach that, we needed to transfuse these people with a hemoglobin pre-transfusion total more than 120, which again highlights the significant amount of blood transfusion that you have to offer with these patients. I don't go because of the interest of time. We also saw significant difference in terms of the iron overloading mechanism in these people, as we thought they had the features of non-transfusion dependent thalassemia patients with a lot of, in addition to transfusion associated iron overload, they had a lot of GI absorption. I won't go through all of this. And this is alpha thalassemia. As you can see, the ferritin would have underestimated the amount of LIC in these patients compared to the beta thalassemia patients. And once we started to hypertransfuse them, it became normal, or expected, like what we see in the beta thalassemia. So there is also iron overload implication and monitoring for these individuals. So to conclude, and I did it right exactly at 11. This is a condition that once was universally fatal. Now a lot more and more of these people would survive, and they will become a chronic disease going forward, and this can significantly add burden, especially in areas that are endemic with this condition. We can expect probably a good neurodevelopmental outcome, but it really requires extensive treatment and multidisciplinary approach. It's a distinct disease. This pathophysiology is really different than beta thalassemia, with one being able to create a hemoglobin Bart's or hemoglobin H, unlike beta thalassemia that doesn't create any hemoglobin, being a hemolytic disease, but also hemoglobin H has no function. It is a totally different, although it's kind of a cousin of beta thalassemia, it is significantly different. And as we talked, there's a major implication for public health. Thank you so much.
Thank you
My
so much.
teacher taught me to finish right on time so nobody can ask any questions. So
yeah. Thank you so much. Well, it looks like we do have a question from Dr.
Okay,
Merkley.
yeah.
So.
Yes, of course.
Hi, Ali. That was fantastic. Thank you so much.
Hi, Ali.
My question is, where are we at with intrauterine transplant? I know early studies were not successful, but is that still an area of active investigation? Is there hope that this could cure these patients in future?
Yeah, so yeah, and I mean, the UCSF is doing this intrauterine transplant, and the name is intrauterine transplant, but it's not really a transplant. So what it does is that it just exposes the fetus with the immune system that has not evolved to mom's cells, allowing identity of self for a future transplant with this haploidentical mother as a donor to proceed it. When they started to develop, we were really pessimistic about the possibility of it, and that's because the disease starts so early on in this, and then there is a significant hydrops already, and the bone marrow is so active, unlike beta thalassemia or other anemias that you can see in the fetus, that it's really hard to have a graft of that mother's cells to the baby and continuous exposure. So I'm interested to see the results. Last I know was that the transfusions did not lead to considerable amount of engraftment going forward. So it would be something that we can see. The challenge of that is also that we can offer IUT in our system, but what they also wanted it to be done in their center, and this just family going to US, all the insurance issues and everything, and travel, and this is a family that is now pregnant, where to stay, how to do it. It is quite a challenging prospect, but we hope that it is a possibility for the future.
Sakura, you have a question?
Hi, Ali. Great
Hi,
talk
Sakura.
as usual. Just to understand the new transfusion concept for alpha tau. And again, you're dealing with the pediatric population, so there's an effect of growth and development as well, right? So, some people believe it's not really in the guideline somewhere, but if you apply the transfusion concept for beta tau, using those Rucalelli guideline or whatsoever to apply to alpha tau. So is that a particular target, like hemoglobin target, that you aiming to get for like certain age group, like smaller kids should be transfused at this level, and when they grow older or became adolescent, then you change the target over there. And then with the frequent transfusion, which or transfuse more, would it affect the like minimize ineffective erythropoiesis, and at the end you will see that hemoglobin H level will come down at some point too, or what is the like mechanisms out there? Thank you.
No, it's a really good question. I'm going to share again my if I can, because I was looking at the time and just kind of went through it quite fast. Oh, this is not the right one. Yeah, so I think so for this alpha thalassemia measure, which the answer is much easier, is that you just do what you do for beta thalassemia, just rather than looking at the total hemoglobin, you just calculate the functional hemoglobin and employ that, meaning that technically, and you can just guess it and going forward and not to do it all the time. But what you do is that you once or twice or three times, you just calculate your hemoglobin H, and then you say, okay, my hemoglobin is 105, my hemoglobin H is 15%, my functional hemoglobin is 90, so it's good enough, I'm just going to continue doing this. Or hemoglobin H is higher, and I have to reduce it with more transfusion that goes beyond just to suppress the marrow and then going down. I think what becomes kind of a little bit more complicated kind of a approach would be how you would do it for hemoglobin H disease. Because some patients with hemoglobin H disease, they will have quite significant number of, like a proportion of hemoglobin H, 30%. And these are actually the ones that who may require regular transfusion at some point. So then that is something we don't know. Hemoglobin alpha thalassemia probably doesn't need by itself as aggressive transfusion as what we do for beta thalassemia, because there's less degree of ineffective erythropoiesis. Like, for example, like for spherocytosis, you don't need to transfuse them to keep them always more than 90. But at the same time, if you just look at the total hemoglobin, you will see that 30% of them is non-functional. Then our approach probably for people with hemoglobin H disease, let's say non-deletional ones, are probably have been wrong for a long time. When we look at the hemoglobin is 95, 90, 85, we say it's good enough. But really we have to look at the non-functional hemoglobin, and then if it is low, then consider starting exchange, look at a higher degree of transfusion. So it's a complex question really that you ask, much easier for these individuals because we know they need regular transfusion, and it is easy to calculate. We haven't figured out perfectly yet for the hemoglobin H disease. And when I say it's easy, nothing is easy when they load so much iron. Most of the patients, they needed to be on two chelations. Sometimes we restart desferal. So it can become quite burdensome, their treatment. I was trying to show you the screen to show that the hemoglobin H did come down. Okay, so here in this slide, here you can see before and after aggressive transfusion, and I don't show it hemoglobin H, but you can see that the soluble transferrin receptor marker of ineffective erythropoiesis become almost normal. The reticulocyte never becomes normal, but it's less. LDH marker of hemolysis is almost normal. Unconjugated bilirubin almost normal. So there was a significant hematological benefit of this approach. I hope I was able to answer your question.
Yeah, thank you.
Yeah.
And it's not just diluted out, right? It's really suppressed the non-functional hemoglobin production. Yeah, thank you.
Exactly, yes.
Dr. Morrison, do you have a question? I see you're on camera now.
Hey, thanks, Krista, and sorry to keep it going, but I thank you, Ali. That was fantastic.
Oh, my pleasure. Thanks, Doug.
Yeah, nice to see you. I was just noticing Dr. Merkley's comment about the screening, antenatal screening, and I sort of agree that we could do a better job of screening parents or pregnant women for the relevant mutations. And the other thing I was going to comment on, when you calculate the percentage hemoglobin H, is that based on an H prep, or are you using HPLC at all?
It's a good question. Nick, I don't know if Nick is here. We attempted to come up with a formula that we can just look at the hemoglobin H prep and calculate it. So if you don't have, so I think the question is, what is the best way, I guess? And the best way is, I think, isoelectric focusing. HPLC is probably not the greatest. The reason is that because this is such a hemolytic disease and there's a lot of hyperbilirubinemia, and then the bilirubin can be seen at the same kind of area that you see the hemoglobin H, and it affects the peak, and you miscalculate it. When we look at the cell, and then we start to count them, but knowing that the MCHC of the hemoglobin H cells is different than MCHC of the donor cells. So simple calculation misses that K or kappa or whatever you want to call it. So there should be a K that you calculate, and then you say, I don't know, like the number multiplied by 1.2 would be the kind of your hemoglobin H disease. We try to do it with Nick, but I think at some point we do it again. we couldn't kind of figure it out perfectly, because we actually observe a lot of very interesting kind of phenomena here that people we didn't know. For example, we thought HPLC, you should do it right away because the cells would degrade right away. But what we noticed is that actually, yes, the cells would degrade right away, but you can still do HPLC in a 1 week old blood sample, because the hemoglobin itself is a little bit more kind of stable than what we thought. So to be seen.
Yeah, cool. Well, the one thing I was thinking about is, with our newborn screening program, the HPLC that's done on the cord samples through the newborn screening, the methodology, the detector, the integration of the peaks begins right at the beginning, and it's easier to pick up the fast hemoglobin peaks. So that was just, I don't know if you've thought it or whatever, but thank you. That was a great talk.
Oh, my pleasure. Thank you.
Yeah, there's just one more question from Eunice in the chat. So wondering what the bilirubin interference would be of cap zone electrophoresis rather than HPLC.
So the HPLC, I think, and I think Eunice is absolutely right that there is kind of an overlap of bilirubin and HPLC for the hemoglobin H. We didn't see that overlap amount in the capillary zone. That's why I think it's better test to do.
Awesome. Well, thank you so much. I definitely learned a lot. I'm learning how much I forget about the things I don't do in real life anymore after training. But yeah, this was fantastic. And for everybody in the crowd, please make sure that you do the evaluations, at least for your attendance, but we would love for you to evaluate Dr. Amid. And thank you again, Dr. Amid, for coming to our talk.
Oh, thank you
Yeah.
so much for having me. Sorry for going over time.
Oh, no, it's perfect. Thank you so much.
You're welcome. Thank you.
Bye.
Bye-bye.